not a small number.
I know he's going to use all that.
Yeah, this is, that's great. I think this is, yeah, great. This is nice. We actually are a Glomerular Center.
Amazing.
Yeah. Yeah. Well, you know what? You know the Glomerular Center is called. And I had to where's I donated to the university, the hospital, or the renal society. I said, the Glomerular Center. And then I quickly told everybody, because now the Glomerular Center, we're printing the brochures, and we did, and it was a million. Yeah. And you need, and a business card. That's correct. Whenever you get a link now. Yeah. Oh, this is all this is all recorded too, right?
Well, that's why we need to.
Oh, okay. Right. Good. Okay. Okay. Okay, if people could take their seats. Yeah. Yeah. We can't help it. Okay, we're going to get this one off.
You know what I'll do, Jerry, is when they come with it, I'll keep it here, and then I can change it.
That's good. Yeah.
And I'll bring it to you, okay?
Great. Now, I am not a Buffalo Bills fan, but there was a reason that we were showing you Donald Jones. So, some of you who have been watching the screen go by saw the letter that he wrote saying that I can't play football anymore, I'm retiring because of my kidney disease. So, Donald was 6 years as a tight end with the Bills, then traded to the Patriots. If he didn't have a creatinine of 4 and wasn't progressing to renal failure, he probably would have been on a Super Bowl team. But nevertheless, he did retire and, has done very well since, and again, no HIPAA violation here. But his disease is IgA nephropathy, and that's one of the diseases we're going to talk about today. We're going to talk about glomerulonephritis today. That is inflammatory lesions within the glomerulus. That can lead to progressive renal failure, either slow or fast. And we'll go through the major categories today. Now, my disclaimers and conflicts of interest are exactly the same as before. And Dr. Degatti still has she's developed no disclosures during the last 2 days.
My heart is pure.
Yeah. So we're going to define the acute nephritic syndrome. We're going to define rapidly progressive glomerulonephritis. We're going to review the clinical and the histopathologic major causes of glomerulonephritis. We'll talk about post-infectious GN. We'll talk about IgA nephropathy and the vasculitic form Hennig-Schönlein purpura. We'll talk about lupus nephritis, ANCA-associated disease, and anti-GBM. We're going to cover a lot of material today. But the first thing we want to do is look at the approach to glomerular disease. When I'm at the Glomerular Center here at Columbia, which is the largest glomerular center in the country, and we're seeing patients with glomerular disease, how do I know what category they're in? How do I know what their manifestations are that would lead to a biopsy, not a biopsy, which tests? 3 major patterns that you can see. 1, nephrotic syndrome. That's what we covered the other day when we talked about minimal change, focal sclerosis, membranous, diabetes, amyloid. It always has heavy proteinuria, heavy albuminuria. You can get a low serum albumin, edema, and high serum lipids. We did all that the other day. Today, we talk about nephritis and nephritic syndrome. This is characterized by worsening renal function, a rise in the BUN and creatinine, if you want to call it acute renal failure or AKI, acute kidney injury, high blood pressure, hematuria, which can be acute, chronic, all of these, acute, chronic, or rapidly progressive. It's not working. Okay. Oh, it is. Good. And the last is asymptomatic urinary abnormalities, which are not rare at all. Somebody will have hematuria, somebody will have proteinuria. They just don't have a reduction of kidney function. They have some minor abnormalities in their kidney, which may be the beginning of another disease that would progress, or on the other hand, it may be something that'll never progress, but we don't get them to a biopsy until we see significant proteinuria or the creatinine going up or something that we think we can treat in a different fashion. So these are the three major categories that you could see. How do we know somebody has nephritis, an acute nephritic syndrome? Well, here's one of the times that looking at the urine sediment under the microscope is crucial. Red blood cells, sometimes these are deformed and crenated. If you don't have red blood cells, it's unusual to have glomerulonephritis and the entities we're talking about. RBC casts, these are red cells packed in the shape of a cylinder because they're all packed into the tubule with a protein matrix. They all come out in the urine. And albuminuria. If you have lots of albumin, again, yes, you could have the nephrotic syndrome, but many patients who have glomerulonephritis also have a significant amount of protein in the urine as well. So these are red blood cells that you're looking at here in the urine sediment, okay? They're from somebody who happens to have a urinary tract infection. Here's a white cell. So you're just looking at, these are coming from the bladder. They don't tell you anything about the kidney. But if you see the red cells all packed together in this cylindrical shape here, that in a protein matrix, you know that that came from red cells that came all the way down the tubule. They're always starting at the glomerulus again. So red cell casts mean that you have glomerulonephritis. The other thing that tells you that you have glomerulonephritis is if you have deformed or crenated red cells. These red cells have to pass through breaks and gaps in the glomerular basement membrane to get out into Bowman space and down the tubule, and Vivette will show you these later on. So you have to get through there, you have to go all the way up and down the tubule with its concentration gradient, and they get deformed. So if you see deformed or crenated red cells, it is just as good a marker as red cell casts. And the ones that really tell you that you're dealing with glomerular disease are the acanthocytes. So I always tell people, if you see red cells with Mickey Mouse ears on them, that's glomerulonephritis. Look for the Mickey Mouse ears. So that's a clinical overview. Now Vivette's going to give you a histopathologic overview, different etiologies and what the histopathology is in general before we come to the specific disease entities.
Okay, so I think this is working now. Is this a clearer sound for you? Okay, great. So let me just begin by saying, what is glomerulonephritis from the standpoint of the pathology? Nephritis, and anything ending in itis, you know means inflammation. You've seen this in other organs where you have hepatitis, dermatitis, you name it. What we're talking about here is an inflammation of the glomerular capillary bed. And this is usually accompanied by hypercellularity in the glomerulus. So we see proliferation of cells in the glomerulus together with inflammatory influx into the glomerulus. And that is what we call glomerulonephritis. When we talk about the different components of glomerulonephritis and how to categorize them, we can approach it in several different ways. We can think, for example, about the immunologic aspects. Is this glomerulonephritis due to the deposition in the glomerular capillary bed of preformed circulating immune complexes? As you'll see, most of these diseases are immune-mediated. Or is this due to in situ immune complex formation, binding of antibody to a planted antigen? We can talk about the specific etiology. In more and more diseases, we understand what the antigen is. 20 years ago, we didn't, but there's a huge advance being made in glomerulonephritis. And we can ask, is the antigen an exogenous antigen, as we see in infections, such as a streptococcal antigen? Or is it an endogenous antigen, as in autoimmune disease, where the antigen is the patient's own DNA or a component of it? We can talk about the morphologic features of the glomerulonephritis. And this is what we do every day under the microscope. We want to look at the pattern of proliferation. Is it confined to the mesangium of the glomerulus? Is it extending into the endocapillary zones, what we call endocapillary proliferative glomerulonephritis? Or is it involving the parietal epithelium forming crescents, what we call crescentic or crescenteric glomerulonephritis? And then, as Jerry just mentioned, we look at the clinical syndromes. Does this patient have acute nephritic syndrome, a rapidly progressive form of glomerulonephritis, which usually means there are crescents? Or is this patient asymptomatic? Is the hematuria, for example, just picked up on a routine urinalysis, a screening for an insurance physical or a school physical or a military physical? Often the glomerulonephritis is picked up in this fashion. So it's by integrating all these different things together with the light microscopy, the immunofluorescence, and the electron microscopy, and the serologies and clinical manifestations that we can reach a specific diagnosis. Now you may ask, we have immune injury going on in our bodies all the time. You brush your teeth, bacteria enter your bloodstream, you form immune complexes. Why is it that of all the different vascular beds in the body, the glomerulus is particularly vulnerable to immune deposition, leading to glomerulonephritis? Well, the reasons relate to a lot of the things we discussed in our first lecture. First, remember that the kidney sees a huge amount of the cardiac output, from 20 to 25%. So if there are circulating immune complexes, the kidney is going to see them. Second, remember the unique anatomy of the glomerular capillary bed between two arterioles, an afferent and efferent. It has the highest capillary pressures of any capillary bed in the body, somewhere between 40 and 50 millimeters of mercury. Bombarding the glomerular capillary walls at high pressures with circulating immune complexes may predispose to development of glomerulonephritis. Third, we have the most highly fenestrated endothelium in the body, which maximizes contact of immune reactants with the glomerular capillary wall. And here, even charge interactions may come into play if you have a positively charged antigen-antibody complex or antigen interacting with the net negative charge of the glomerular basement membrane. And then you also have a concentrating or sieving effect. This is this filtering organ, so a lot of filtrate is passing out. If you have large immune complexes, they're going to be concentrated in the glomerular capillaries compared to other capillary beds, and this may also predispose to development of glomerulonephritis. As we talk about mechanisms of immunologic injury, there are three main forms that you should keep in mind. One is glomerular deposition of circulating antigen-antibody complexes that are preformed. They're in our circulation. In this type of glomerulonephritis, you can think of the glomerulus as kind of an innocent bystander that in the course of its normal filtering functions non-specifically traps these circulating immune complexes in the glomerular filter. The immune complexes themselves have no specificity for the glomerular constituents. Second, there can be binding of circulating antibody to a fixed glomerular antigen. That is, that a glomerular antigen is the actual target of immunologic attack. And we're going to talk about a specific disease here, anti-GBM nephritis, where it is the collagen 4 component of the glomerular basement membrane that is the target of immunologic injury. And third, you can have what's called in situ immune complex formation, where an antigen is first planted in the glomerular capillary wall. It may be even locally synthesized there, but it's a movable antigen. We discussed this in membranous glomerulopathy, where the antigen is capped and shed off the clathrin-coated pits into the subepithelial space. And then once planted, antibody binds to it in situ. So these are the three major mechanisms we're going to talk about. In mechanisms 1 and 3, the immune deposits are typically granular in appearance when we look by immunofluorescence, whereas in this anti-GBM nephritis, the immune deposits, the IgG, is typically linear, as I will show you. So based on their size, charge, and other physical properties, their avidity and affinity, immune complexes can deposit in a variety of locations. And here I have a diagrammatic that shows you the mesangial areas and the capillaries coming off them as cut in cross-section to show you that deposits can form in various sites. If they are located within the mesangium between mesangial cells, or right internal to where the endothelium lies, within the mesangial matrix, we call those mesangial deposits. Deposits can also form between the endothelium and the glomerular basement membrane. They're subendothelial, beneath the endothelium, along the inner aspect of the glomerular capillary wall. They can also form on the outer aspect of the glomerular capillary wall between the visceral epithelial cell and the GBM. We call those subepithelial, and you saw that in a situation of membranous glomerulopathy. Now, in some diseases, such as primary membranous glomerulopathy, the deposits only form in one location. They're subepithelial in that disease. But in some diseases, like lupus nephritis, which I'll show you, the deposits can form in any of these locations, and often multiple locations simultaneously. Sometimes the deposits are large enough for us to see them by light microscopy, but that's unusual. Usually we need the techniques of immunofluorescence and electron microscopy to more carefully localize the distribution of the immune deposits and to determine as well their composition. Are they IgG, IgM, or IgA? And knowing this helps us to categorize glomerulonephritis. So what happens once these deposits form in the glomerular capillary wall? Well, these immune deposits, as shown here schematically, activate complement. That's a very critical process. Here you see C1q and activation all the way to C5b9. With the release of chemotactins, in particular C3a and C5a, we recruit leukocytes to the glomerular capillaries. This is a critical step in the initiation of glomerulonephritis. Here you can see a polymorphonuclear leukocyte coming in, and once present in this location, it becomes activated. It releases its lysosomal enzymes, proteases, reactive oxygen species onto the glomerular capillary wall. These enzymes digest the endothelium and portions of the glomerular basement membrane, and through these breaks in the glomerular basement membrane, formed blood elements like red cells can escape. With the endothelium denuded here off the glomerular basement membrane, we can activate the clotting cascade. And so we have Hagemann factor, factor 12 of the intrinsic clotting cascade, fibrin, plasmin, kinins become activated, and very critical, macrophages or monocytes, as they come into the capillary wall, also recruited by Fc gamma receptors in many cases, release their cytokines, both inflammatory cytokines such as platelet activating factor, platelet-derived growth factor, and fibrogenic cytokines like TGF-beta. These cytokines can act on platelets to cause coagulation, or they can act on indigenous glomerular cells, in particular mesangial cells, that respond by growth and production of matrix, leading to the pathology that we see in glomerulonephritis. In particular, platelet-derived growth factor is a very strong growth factor for mesangial cells, and TGF-beta, a very strong fibrogenic cytokine that can progress to mesangial sclerosis and permanent glomerular scarring. So based on the location of the deposits and their quantity and other factors, the glomerulus can respond to this onslaught, this attack, in different ways. But what we see under the microscope is generally a proliferation. And we have different patterns of proliferation that I'll show you in the various diseases. Sometimes in the mildest forms, we only have hypercellularity in the mesangium. But in the more severe forms, we can have endocapillary proliferation. Here in this cartoon, if you consider the black line here to the glomerular basement membrane, you have proliferation of cells within the confines of the GBM. So this is usually proliferation of cells that normally reside there, endothelial cells, mesangial cells, as well as infiltrating leukocytes. In more severe forms of disease, we can see proliferation outside the glomerular basement membrane, sometimes with endocapillary hypercellularity, and these extracapillary so-called proliferations make a crescent-like, almost like a crescent moon appearance along the inner aspect of Bowman's capsule, and that we call crescentic or crescenteric glomerulonephritis. That's a very severe form of disease. The other thing that we look at as we look at biopsy under the microscope, we have many glomeruli, sometimes 20, 30, 40. We look to see the distribution of the glomerular involvement. Does it involve just a small proportion of the glomeruli, what we call focal, if it's less than 50% of the total number of glomeruli? Or is it diffuse, involving the majority of glomeruli, more than 50%? And then as we look at the individual glomeruli themselves, we look at the pattern of injury. Does it involve just a segment of the tuft, what we call segmental, or the entire glomerular globe, what we call global? And you saw an example of this when we talked about focal segmental glomerulosclerosis. There we were talking not about a glomerulonephritis, but a sclerosing disease where the process was focal and segmental early on, involving some glomeruli, not others, early in the disease, and just a proportion of the glomerular tuft. So you'll see us using these terms as we discuss the diseases ahead. So we'll start off with case number 1, and Dr. Appel will give us the clinical history.
That's why I love renal pathology. The pathologists say it exactly like it is. You'll have many different organs to study, and you'll see, when they talk about the liver and they talk about chronic active passive-aggressive hepatitis, it's a little confusing or usual or unusual interstitial disease. Here you see it exactly, focal segmental, diffuse proliferative global sclerosis or proliferation, etc. You'll get the exact thing. The other thing is, remember the crescents, like the proliferation, that's very important. I was at a conference last week in the Dominican Republic, a renal conference. They were literally, the translators were translating from Spanish back to English for me, and they were saying, here you can see in this glomerulus many half moons, when they were talking about the crescents there. But don't say half moons when you're talking to nephrologists in the United States. Anyway, onward to a 7-year-old boy with a sore throat. So this 7-year-old child had several days of a sore throat, a low-grade fever. He's given acetaminophen, and he recovers uneventfully. 2 weeks later, and this is crucial that it's 2 weeks later, he develops dark Coca-Cola-colored urine, and he notes that he's urinating less. He has swelling of his feet, and his blood pressure, when it's checked by his pediatrician, is now high. When they look at his urine, he has lots of red cells. He has red cell casts. You know this child has glomerulonephritis if he has casts. He has some protein. He has 2+ protein, but the key here is the red cell casts. They measure a creatinine. Even for the largest adult, you take Alonzo Mourning, his normal creatinine was 1.7 with huge muscle mass. Here's a child with a creatinine of 2.2. That is acute kidney injury, AKI, and here it's going to be due to glomerulonephritis. They measure a serum complement value, a total complement. It is low. They then measure the third component of complement, and it is also low. And this tells us which complement pathway. It's the alternate pathway. And they measure a titer of an antibody against recent streptococcal infection. Anti-streptolysin O, very high. So it fits with this recent streptococcal infection. The complements are still low. There's some protein and red cell casts, and there's renal dysfunction. At the same time, there's hypertension. This is just a look down this child's throat. Big swollen tonsils. You can see the white exudate, etc. This is bad upper sore throat infection, etc., that is associated, of course, with streptococcal disease sometimes. So what is a definition of the nephritic syndrome? We said that on that first slide back there. First of all, you get a decreased GFR. The glomerular filtration rate is reduced, and that's easy to picture. When you see the pathology in a few seconds, when Vivette comes up and shows it, you'll see that the glomerulus is filled with cells. You can picture that that glomerulus can't filter normally. The GFR will go down, and hence the BUN and creatinine are elevated. There's decreasing urine output. Again, inflammatory lesion in the glomerulus. You're just not filtering at all. There's salt and water retention because of the decreased GFR. That gives you edema, and it also gives you hypertension.
And you have an active urinary sediment, red cells, red cell casts. If you look at the urine here, people who have very heavy proteinuria in the nephrotic syndrome that we talked about on Monday, they have bubbly or foamy urine, because if there's protein and especially albumin in the urine, the bubbles don't break apart when urine hits the toilet water. Here, you get this smoky or tea-colored or Coca-Cola colored urine. And everything that we see here can be related back, the pathophysiology, to what we see on the pathology.
Okay, so let's see the kidney biopsy from this young child with the streptococcal pharyngitis. And now we're going to put to use some of the terms that I just taught you in the previous slides. And you can see this is a proliferative process. We have a lot of inflammatory cells infiltrating the glomeruli, and you can see that it's diffuse and global in distribution. It's involving all the glomeruli in the biopsy, and as we look at the individual glomeruli, the whole glomerular tuft is affected by this endocapillary proliferation. If we look at higher power, not surprisingly, we can see proliferation of the indigenous cells. These are mostly mesangial and endothelial cells. We'd have to do special markers to identify them. But you can also make out, just from their nuclear characteristics, the presence of polymorphonuclear leukocytes, neutrophils, which are infiltrating in abundance in these glomerular capillaries. Dr. Appel alluded to the fact that the GFR goes down in these patients, and in careful morphometric studies done by my predecessor years ago in the first series of patients with post-streptococcal glomerulonephritis from the 1950s, what he did was he graded the amount of glomerular capillary obliteration on a scale of 0 to 4+, 4+ being the most severe, and then he correlated this with the creatinine clearance and the blood urea nitrogen. The BUN we had increasing with increasing obliteration, but a very good linear distribution with decreasing GFR, because as you remember, you're closing off these capillaries, and in our Starling mechanisms, remember KF, which is the hydraulic permeability times of the capillary wall, times the surface area for filtration is key in determining single nephron GFR. So if you have lost your surface area because the glomerulus is filled with cells, the GFR is going to decline, and because of this volume overload, we get edema. The edema is not because these patients have heavy proteinuria and hypoalbuminemia. The edema here is because they have oliguria, they're fluid overloaded. So it's a different mechanism from in nephrotic syndrome. Now, what are the immune deposits in this disease? We're using our special stains now. You may recall I mentioned that we like to use the trichrome because it shows us the deposits as red against the blue of the glomerular basement membrane. And you can see these red deposits large enough to be seen by light microscopy. They look almost like strawberries sitting on top of the glomerular basement membranes here. And you can again see the many infiltrating neutrophils. They have a hump-shaped appearance even by light microscopy. And then when we go to the electron microscopy, we see the characteristic humps of post-streptococcal glomerulonephritis. These are large deposits, big enough to see often by light microscopy, and they almost look like the dromedary hump on a camel. That's how they got their name of hump. They sit on the subepithelial aspect, and you may say to yourself, well, that's what we see in membranous glomerulopathy as well, but there are some differences here. Here there are no intervening spikes. And here we have proliferation in the glomeruli, as I showed you by light microscopy, whereas in membranous glomerulopathy, you have no proliferative response. So here we have the humps, and you can see them again here. There is some albuminuria, but not often at the level of full nephrotic syndrome, and you can see the foot processes are effaced in areas of protein leakage overlying these deposits. So here's a cartoon to show us the subepithelial humps on the outside of the glomerular basement membrane, the leukocytes coming in, and some astute students in the audience every year ask me the same thing. Well, if complement is activated and you're getting leukocyte recruitment, why is it if the deposits are out here in the subepithelial space that we're getting leukocytes? And the answer is that complement is also being activated in the endocapillary zone because we have small deposits as well in the mesangium and in the subendothelial region. It's just that the humps are so much more numerous, so much more obvious. that we tend to think of them in the setting of this disease, but we also have some deposits in this location where they can activate complement and recruit leukocytes in the endocapillary zone as well. When we do immunofluorescence, we see granular deposits of IgG and C3 in a kind of starry sky pattern. It's almost like looking at the, at the sky on a day when there are no lights in New York City. And you can see the galaxies. It's a lumpy, bumpy, granular appearance. Maybe you have to go to Maine to see this, but it's often called a starry sky appearance, IgG and C3. And each of these little dots of positivity here corresponds to the humps. Now, as the leukocytes come in and they release their lysosomal enzymes, they do damage to the glomerular basement membrane, and gaps in the glomerular basement membrane can form. And it's through these gaps that at high hydrostatic pressures, red cells can be propelled out through the gaps into the urinary space and make their way into the tubules where they normally would never enter. And here you can see a peculiar shaped hump. Here you can see a mantle of visceral cell cytoplasm in an area of effacement of foot processes. But it's through these gaps that we have red cells extravasating out into the urinary space. Here is Bowman's capsule. Here is the glomerular capillary wall. And you can see individual red cells have made their way out into the urinary space. And once here, they can pass on down through the tubular outlet. They enter into the more distal segments of the tubule, and here they tend to amalgamate in the matrix of a protein called Tam-Horsfall protein produced by the distal tubule, and they form an actual mold of the tubular lumen. So they actually form the shape of a tubular lumen, and that's how we recognize them when they pass out into the urine. And when we see these red blood cell casts, we know that the bleeding has come from the renal parenchyma, that those red cells have been in a tubule. And it's a marker of glomerulonephritis. It tells us that this was not bleeding that came from the lower urinary tract. It didn't come from the bladder or the urethra or some other location. It came from the renal parenchyma. Now, if you have trouble recognizing a red blood cell cast, look at the company it keeps. You can see the biconcave red blood cells here, adjacent to this red cell cast. If we look at the gross appearance of the kidney, and thankfully we don't see patients dying from this disease anymore, so this is another slide that I inherited from my predecessor back from the early 50s, where a young girl with post-streptococcal glomerulonephritis died because she didn't have access to dialysis during the period when she had acute renal failure. And it gives us an opportunity to see what the gross appearance looks like. We have a swollen kidney, and you can see these little red dots on the surface of the cortex. This has been given the kind of poetic name flea-bitten kidney, as if fleas came and took a little bite of the kidney and there was a little area of interstitial hemorrhage. But we now know that each of these little red dots actually corresponds to red blood cells in the tubules. They're tubular casts that we can actually see from the surface of the kidney. And this is evidence of the hematuria. So, what do we know about animal models that may correspond to post-streptococcal glomerulonephritis? We have a very good one-shot serum sickness model that was made some decades ago, but which it gives us vast insight into the mechanisms of post-streptococcal glomerulonephritis, where we know the antigen is a streptococcal antigen. What was done in these experiments is that rabbits were injected with a foreign antigen, in this case I-131 labeled bovine serum albumin. So this was a foreign antigen, and you can see the antigen being given at day 0 here, and we can track it over time. We see when antigen-antibody complexes are formed, which is at about 7 days, so it takes about 7 days for the animal to develop an immune response to the foreign antigen. Once it reaches a critical level, we can see complement up top here being activated, and we dip our complement levels. As complement is activated, we develop the disease phase. And here we have antigen-antibody complexes depositing in a variety of locations. In the kidney, they give rise to a glomerulonephritis that resembles post-streptococcal glomerulonephritis. They can also deposit in vessels, producing vasculitis, in the heart and in joints, producing arthritis. As the antigen is consumed, antigen-antibody complexes disappear, and here, after more than 2 weeks, we begin to see just free antibody appearing in the circulation. And so in our patients, too, weeks after an post-streptococcal glomerulonephritis, the anti-streptolysin O may stay elevated in the serum for weeks or months. So there are a lot of similarities with the human disease. One is the lag time. It takes time for the primary immune response to form to a foreign antigen, and so we often see post-streptococcal glomerulonephritis 10 to 14 days after the first development of the streptococcal pharyngitis, because it takes time for the immune response to develop. Second is the fact that not all the rabbits injected develop disease. I'll ask how many of you here have had a streptococcal pharyngitis in your life? I'd be surprised if anybody hasn't. Is there anyone in the audience who's had a streptococcal glomerulonephritis? Some years we have somebody.
Please see me after the
Yeah, Jerry will sign you up. But it's because the host response is critical to the development of glomerulonephritis. If you are a huge antibody responder, you form large immune complexes that are very rapidly cleared by the reticuloendothelial system. They don't deposit in the glomeruli. If you're a poor antibody responder, you don't initiate enough of an immune response to produce disease. On the other hand, if you produce intermediate-sized complexes in relative antigen excess, you may be more prone to development of glomerulonephritis. And we know particular strains of the streptococcal organism, the group A beta hemolytic strep, particularly strains 12, 4, and 1, are more nephritogenic. And then the other similarity with the disease is that it is self-limited. The disease resolves on its own after a period of time, usually in the human about 6 weeks, and so in the rabbit too, as the antigen is consumed and free antibody appears, the glomerulonephritis subsides. So this is what happens in the resolving phase of the disease. The deposits begin to resorb and become more electron-lucent. The antigen, we think, is a streptococcal antigen that's been identified as pyrogenic exotoxin B. It is a virulence factor that prevents opsonization of the pathogen. Remember, opsonization is a process by which a pathogen is marked for elimination by a phagocyte, either by binding of antibody or complement C3b. And so having this factor protects the strep from phagocytosis. So the humps become more electron-lucent, and gradually the disease begins to resolve. And in the resolving phase, all the leukocytes disappear, the deposits resorb, and we're left with just a mesangial hypercellularity in this resolving phase if we do a biopsy late in the course of the disease, and eventually this will resolve as well. But there is a subset of patients who develop a much more severe picture, one where they not only have endocapillary hypercellularity, but also proliferation in the extracapillary zone, which we call crescents. And this fortunately involves less than 2% of all patients with post-streptococcal glomerulonephritis, but it's a very dire finding and has a high likelihood of progression to end-stage renal failure. And this is an example at autopsy of a patient who'd had streptococcal glomerulonephritis while he was in the service in World War II and died many years later of renal failure and was found to have really an end-stage kidney where the glomeruli had been replaced by these balls of collagen 4, which we call glomerulosclerosis. They're no longer filtering. Remember that the tubules depend on the glomeruli for their blood supply. They get their blood supply from the efferent arteriole. If there's no vascular supply to the glomerulus, the capillaries are obliterated by collagen, then there is no flow through the efferent arteriole to feed the tubules, and they become atrophic. There's also a functional atrophy of the tubule as well, as it no longer receives filtrate. And there is interstitial fibrosis and even arteriosclerosis. So in this end-stage picture, all compartments of the kidney reach a very chronic phase, and it's hard sometimes to even know what the original disease was unless you have a prior biopsy. In chronic glomerulonephritis, if we look at the gross kidney, we can see that it's contracted, it's small in size, and it has a granular appearance to the surface. This has been called a leather grain appearance, almost looks like a rawhide appearance to the surface of the kidney, and it has a bumpy quality. And these bumps correspond to areas of elevation where we have residual functioning nephrons that hypertrophy, and areas of depressions that are scarred nephrons. So you get this alternating scarring, hypertrophy, that gives you this bumpy, granular, leather grain appearance to the gross kidney. If we bivalve the kidney and actually look at the cortex, you can see that it's atrophied. Remember, the normal cortex is somewhere between 1.2 and 1.5 centimeter in thickness. Here, they're very atrophic, sometimes maybe 3 or 4 millimeters in thickness. A very thinned cortex. And so in these end-stage kidneys, the whole kidney can become very small and contracted in chronic glomerulonephritis. Here's the normal by comparison. We talked about minimal change disease with its lipid-rich, swollen kidney, and acute glomerulonephritis with the flea-bitten appearance. Here the pathologist has taken out a slice of the kidney for pathologic analysis. That did not come along with the disease. So streptococcal pharyngitis or streptococcal skin infection are not the only causes of post-infectious glomerulonephritis. We have to think broadly about this disease, and something you're going to see on the wards is patients who have endocarditis and develop this disease. Here you see a bacterial colony within a heart valve, and this can be a source for immune stimulation and development of a different kind of post-infectious glomerulonephritis that we call endocarditis associated. In this case, we can see, if we look at the glomeruli, a different pattern of injury. Instead of being global in distribution, often the involvement of the glomerulus is more focal and segmental. And in the old days, what the pathologist assumed was that the vegetations were falling off the valve and actually embolizing to the kidney and producing these localized lesions. But we now know that we even see this disease with right-sided endocarditis, that we have circulating immune complexes, low serum complements, and the same immune stimuli that we see with infections in other sites. So let's hear how this patient fared.
So for post-streptococcal GN, Vivek just said, it follows certain strains of streptococci. If you take this and you take strep throats, I mean, everybody gets strep throats, and a lot of us are colonized by strep, but not everybody gets glomerulonephritis. So it's usually a group A beta hemolytic strep. It can be pharyngitis, worldwide, dermal infections, skin infections, impetigo, other things like that are very common. Children, much more commonly than adults. This is not a common lesion in adults at all. In kids, it's not uncommon, but again, not the most common. That there is a time lag, and this is crucial because, as Vivek pointed out, you have to develop an antibody response to streptococcal antigens. So you have a sore throat, you don't get glomerulonephritis the day you get the sore throat or the next day. You get the glomerulonephritis 10 days later, 14 days later, after you've developed an immune response to streptococcal antigens. And you'll see that's crucial in distinguishing this disease from the next very common disease entity that we're going to talk about. The classic picture is a nephritic picture. You don't have to have a nephritic picture, but again, hypertension, oliguria, decreased GFR with a high creatinine, and active urinary sediment with red cell casts. That's the nephritic picture that's typical. The serum complement level is low, and the third component is low. So when you think of that, we're going to talk about a variety of serologic tests today. You know, we didn't talk about this. Every time we came to this on Monday, I said, we'll talk about this on Wednesday. We'll talk about the serologic tests. You'll see we'll talk about anti-glomerular basement membrane antibodies. We'll talk about ANCA, anti-neutrophil cytoplasmic antibodies, anti-DNA antibodies in lupus. If you were on a desert island, this is the one that you have to know. Complement and C3, and we'll talk about that. You have positive serologic tests for recent streptococcal infections. This person had an ASLO, an antibody titer against it, and the prognosis in kids is wonderful. Very few of them have progressive disease. In adults, it's not quite as good. It may be for who gets it or how they progress or underlying disease from, other causes, but nevertheless, that the prognosis in kids is great. So I said, if you're on a desert island, you may have already had lectures. You have had lectures by Andy Bomback. Well, Andy can tell you when he was a student, this is one thing he remembers from his lectures here, because I've been saying it for years and years to the students, to the house officers, to my fellow attendings. If you're on a desert island with a person with glomerular disease and you can do one test, what would it be? The answer is the complement. Because there are only 4 major disease entities that give you renal disease and a low complement. Post-infectious, that we're talking about, whether it's post-strep or endocarditis, lupus nephritis, that we'll talk about, MPGN, that we're not going to talk about, it's an uncommon entity in terms of unless it's associated with certain things, and cryoglobulinemia. These 4. Everything else has a normal complement. IgA nephropathy, ANCA-positive RPGM, anti-GBM, minimal change, focal sclerosis. Remember, so forget about this list. You don't have to worry about this. You just have to remember the 4 that are low. Immediately it tells you what other tests you should be looking at and which ones are less likely to be important. So remember that the next time you're on a desert island. Okay, now with that, we're going to the next case, and this is something that is often confused with post-streptococcal GN. Now we have a 16-year-old high school junior who notices dark urine after playing basketball. Tells his family, mother takes him into the pediatrician or the internist. His creatinine is 1.1. He's got a good clearance. He's big, he's fully grown and has a pretty good creatinine clearance. His urinary sediment, though, has red cells and red cell casts. You know he has a glomerular lesion. He has proteinuria, 600 milligrams per day, but it's nowhere near the 3.5, 4 grams that you need to have nephrotic syndrome. Serologic tests, complement, ANA, anti-neutrophil cytoplasmic antibody, anti-GBM, hepatitis B, everything is normal or negative. So what does this high school basketball player have? The same thing that Donald Jones, the Buffalo Bill football player, had. And you'll see it in a second.
And that disease is what is becoming one of our most common forms of glomerulonephritis, and that is IgA nephropathy. IgA nephropathy, and you can see now why this patient had a very well-preserved glomerular filtration rate, usually manifests with just mesangial hypercellularity. That's the most common finding. Here you can see 2 glomeruli, and you can see that we have increased number of cells. More than 3 nuclei is mesangial hypercellularity, but it's confined to the mesangium. The capillary lumina are patent, so this patient is still filtering well, and the GFR is preserved. So we have a mesangial proliferative glomerulonephritis. It's diffuse and global in its involvement. Well, again, we pathologists name things very aptly when we see them. We do our panel of immunoglobulin staining, IgG, IgM, IgA. What we find is IgA, dominant staining in the mesangium. Here you can see it again in the centrolobular regions of the tuft. You can see the peripheral capillaries here. I'm outlining them. They have no deposits. They're clear of deposits for the most part. And these bulky deposits are present in the mesangium, and they stain most strongly for IgA. You may have other immunoglobulins, a little bit of IgG and IgM as well, but not as intense as the IgA, which is usually 2+ or 3+ in intensity. This is IgA nephropathy. And here, by electron microscopy in a cartoon, we can see how the deposits are primarily located in the mesangial areas, often right where the glomerular basement membrane reflects over the mesangium. They tend to cluster in this region. The mesangial cells respond by proliferating. And we may have a few deposits out in the periphery as well, but the bulk of the deposits are within the mesangial regions. IgA nephropathy. Here it is in an actual patient where you can see the electron-dense deposits filling out the mesangial region. Here we have the glomerular capillary lumen. It's patent. Here's another. But we know there have been some breaks somewhere in the glomerular basement membrane. There might be one even right here. And red cells have come out and entered the urinary space, and so this patient developed hematuria. IgA nephropathy can affect many different age groups, but it is most common in about medical student age, 2nd and 3rd decades of life. So every year we have at least one person in the audience who's had IgA nephropathy or who has it. So I won't ask you to identify yourselves, but you're going to make an appointment with Dr. Appel later. And it's a disease that is more common in males, 2-to-1 incidence, and it's unusual in African Americans, actually, if we look at the different ethnic groups. Worldwide, it seems to be increasing in incidence, or at least we're recognizing it more. We see it in all different portions of the world, but particularly high incidence in Asia. What is the pathogenesis of this disease? Well, we're learning a lot more about it. It was recognized in the early days by the French, who loved to drink fine wines, that when patients develop alcoholic cirrhosis, they can develop IgA nephropathy. And that is because IgA immune complexes, the Ig1 polymeric, is picked up by hepatocytes and actually excreted to some degree in the bile. So patients who have altered hepatic function, like alcoholic cirrhosis, can develop IgA nephropathy. But that's not the most common scenario. Much more common is a patient who has had a recent inflammation of the IgA mucosal system. Remember, our plasma cells produce IgA mostly in the bronchi and in the GI tract. So if you've had an upper respiratory tract infection or gastroenteritis and you have increased IgA synthesis in response to some infection, like a viral gastroenteritis, this may be an inciting event. It also could be that because of the inflammation in the mucosa in these sites, you have a defective antigen exclusion. You disturb the barrier, the mucosal barrier. So IgA normally complexes with the antibody in the lumen of the gut or in the lumen of the bronchi and is expelled externally from the body. But if you have a mucosal barrier where there's a lot of inflammation and disruption of the mucosa, the IgA immune complexes could then enter back into the circulation and could deposit secondarily in the glomeruli. But much more important now, as we're increasing our knowledge, is that we recognize that there is a defect in the IgA molecule itself that may be important and may render the IgA an autoantigen, in which case antibodies can form to the IgA molecule. And this autoantigen depends on how the hinge region of the IgA is galactosylated. IgA comes in two flavors, two subtypes, IgA1 and IgA2. We know in this disease it's polymeric IgA1 that is the main culprit. And this is the form that has a hinge region where there are O-glycans that are formed here, and these are galactosylated. And we've learned that patients who develop this disease often have defective galactosylation of the hinge region. This may render the IgA molecule immunogenic and may also make it more prone to deposit in the mesangium and to be resistant to clearance from the mesangium. And that may be important in the pathogenesis of the disease. We recognize a renal-limited form of IgA, which is known as IgA nephropathy, where you just develop glomerulonephritis. But there is a systemic form of the disease, which is sometimes called IgA vasculitis by the new nomenclature, and this is often referred to as Hernach-Schönlein purpura. Here we have not only glomerular involvement, but we have other portions of the body affected by IgA deposition, including the joints, the gut, the skin, which leads to the purpura. So Hernach-Schönlein purpura goes by the name of two German pathologists. One of them photographed here probably in the late 1860s. This was Edward Hernach. And here Schönlein, who came earlier, and we don't even have a photograph of him, just a drawing. But you can see that Hernach actually identified all four manifestations of the disease clinically. So usually people put his name first. Schönlein recognized the purpura and the arthralgias, not the full syndrome. But when you have this multi-system IgA deposition in other capillary beds other than the glomerulus, it goes by the name of Hernach-Schönlein purpura. And here you can see an example of a patient who developed the purpuric rash. It's usually in the lower extremities, and it's actually a leukocytoclastic vasculitis where there is deposition of IgA in the dermal capillaries. And here is an example showing you the lesions on the shins of this patient. Purpuric. The dermal capillaries, a biopsy was done here, and show vasculitis with deposition of IgA within them. And similar lesions can be found in the gut, giving rise to abdominal pain and sometimes hematochezia or bleeding from the gut, and can also involve the joints as well, leading to arthritis. And with the stain for IgA, when there's glomerular involvement, we also have Hernock-Schönlein purpura nephritis. It looks identical to IgA nephropathy in most cases. So let's hear what happened.
So this is a disease where there's been a lot of progress recently, especially in understanding the pathogenesis and understanding the genetics of the disease. But as Vivette said, it's the most common form of idiopathic glomerulonephritis worldwide. So, I mean, in fact, it's still the #1 cause of renal failure in China. So, in the Far East, very, very common. Again, it's defined by the IgA deposition in the mesangium. If you don't have IgA on IF or another technique, if you don't have it, you don't have IgA nephropathy that day. Clinical presentation, 2 patterns. Young people who get gross hematuria, that is dark urine, following usurtion or upper respiratory infections. In fact, it's called synpharyngitic. Now, we said before the streptococcal infection in that young 7-year-old led to a glomerulonephritis. But remember, there was the time lag, 7, 10, 14 days to develop an antibody response. That's not what happens here. Here, there's no time lag. Right at the same time you develop the sore throat, you get dark urine, because this process is going on all the time in these kids and young adults. And the serum complement value is normal. So you have pretty good ways to distinguish it. In adults, much more commonly picked up asymptomatically. It can be, you think about the urinalysis. When do we do it? The most important times in your life, you get a urinalysis. You go out for a sporting event. You go into the army. You get pregnant and they're following you. They keep dipsticking the urine looking for protein in blood. Well, here, that's how it's picked up. Insurance physicals, army physicals, etc. They find somebody with protein blood, nothing else. They end up doing the biopsy, and it's IgA nephropathy. Originally, it was called benign recurrent hematuria because Berger noticed in kids playing soccer that they had episodes of dark urine, and they didn't follow a more progressive course like some of the post-streptococcal ones did. But it's not benign. 20 to 30% will progress to renal failure, end-stage renal disease, over 20 years, and it's more at 30 years and more at 40 years, etc. We just hadn't followed the people long enough. There are very good treatment options now. We now have good data that blocking the renin-angiotensin system makes a difference and slows the progression from controlled trials, and I'll show you that. Steroids, in a number of studies, corticosteroids, prednisone, have slowed the progression to renal failure, reduced proteinuria in certain patients. And then there's a bunch of other things that have been done, tonsillectomy fish oils, that I want to mention because you're going to hear about this, and I'll show you what the evidence is or is not. So here's a study that Christoph Kirilluk, who is the first author, Ali Gharavi is, you can see along the line there, and much of the genetic work has come out of Columbia from their labs. This shows what goes on in terms of the abnormal galactosylation of the IgA1 molecule. Let's look first at this panel. The higher you are up here, the more galactose-deficient IgA you have in your circulation. Here you can see controls. Here you can see IgA kids, IgA nephropathy kids. They have more circulating galactose-deficient IgA. The interesting thing is, if you look at their first-degree relatives, they have the same thing. You take an adult with IgA nephropathy, they have galactose-deficient IgA. If you look at their brothers, sisters, mothers, fathers, many of them will have this. If you look at their spouse, they won't at all. So again, there is a genetic component to this. The other thing that's very important is HSP. And if you don't want to say Hernock-Schönlein purpura, just HSP. Is HSP the same disease or a different disease? It's probably the same disease with systemic manifestations, because here are the HSP cases with much more galactose-deficient IgA, and their relatives too, versus the controls. It's the same thing. So you have an abnormal IgA molecule. Your immunoglobulin IgA is abnormal. Then you develop an antibody to it. Now, this is IgG antibodies against galactose-deficient IgA molecules. You can also develop IgA antibodies against galactose-deficient. But you can see the patients have much higher levels of circulating IgG antibodies against galactose-deficient IgA than disease controls or healthy controls. So the thought is a three-step process. Somehow we generate, from a genetic background, we generate galactose-deficient IgA. Then certain patients, not the relatives, but certain patients develop antibodies, autoantibodies against this, and then the immune complexes land in the kidney, in the mesangium, and rest of the capillary wall, and this gives you IgA nephropathy. Now, what about the therapy? Every study that's been done with an ACE inhibitor or an ARB is positive. Here, you're looking at one study, randomized controlled trial of ACE inhibitors. If they didn't tolerate the ACE inhibitor, the most common side effect is cough. But if you didn't tolerate and you took an A2 receptor blocker, again, everybody in one arm got one of these two drugs. The people started with a pretty good creatinine, but they had to have over 500 milligrams of proteinuria. So they were in a group that might have progressed. 75 months follow-up. This is the group that had a 50% increase in their serum creatinine. They were progressing to renal failure. Here's the treated group. Here's the placebo group. Again, at the same blood pressure control. And there are many studies that show that. So ACE inhibitors, ARBs, this is a good disease to use it in anybody with any degree of proteinuria. Tonsillectomy. Mothers and family members constantly come in with young people saying, should I have him have his tonsils out? Should she get her tonsils out with her IgA nephropathy? Because there are some studies in the literature that suggest this. There are also many studies that say it doesn't work. And the thought is that somehow you're generating the galactose-deficient IgA in response to certain infectious agents, mucosal invasion here, by certain organisms. In any case, this is the study that's most often referred to. Here, if you look at the rate of renal survival in a tonsillectomy group versus a non-tonsillectomy group, it was better. And this isn't a good kidney journal, but it's many years ago. It was a retrospective study, not randomized control. And how long did it take to make a difference? In this study, this you're looking here is not days, it's months. So where did the curve split? About 120 months, 10 years. If you see somebody whose creatinine is 2.3 with IgA nephropathy, it is not likely that they're going to be around not needing dialysis or transplant 10 years from now. So again, whether it makes a difference very early or not, we don't know. They do it a lot in Japan, but most of the data suggests that it's not supported by good randomized trials. The other thing that's commonly done is fish oils. And you'll hear, people use fish oils for everything. It is used after myocardial infarction in Europe a lot, again, because it's an antiplatelet agent. It does decrease platelet stickiness. So fish have some very good oils in them, eicosapentaenoic acid and docosahexaenoic acid. Those are both good fish oils, omega-3 fish oils. And some of you, I bet if I asked how many people were taking it, we find a lot of people in the class taking fish oils. And if not, your parents are taking it. But in any case, there are a bunch of bad players too, thromboxanes, lipoxygenases that are not so good. So some people do take these over-the-counter ones. We don't know. It's very hard to know what's in them. I would just point out, if you want to get your fish oils from fish, what you have to do is eat herring. If you eat herring, if you live in Amsterdam and you eat a lot of herring, you're okay. But if you think you're getting a lot of fish oils from salmon, it depends on what type of salmon it is. And as some of you know, if you're in Alaska, you can ask the waitress. They'll know the difference between the sockeye and the Chinook salmon. They'll tell you, oh, the king salmon is at sea longer and it's fattier, da-da-da. They can tell you all that. But try finding that out in New York City. In fact, in New York City, we can't even tell the farm-raised from the ones that are wild. They did testing, genetic testing on something like a dozen major restaurants in New York City, big-name, expensive restaurants, and they found out that out of the 12 or so restaurants they tested, something like 10 of the wild salmon were actually farm-raised. One was equivocal, and only one was a truly wild salmon out of the group. So, and if you think you're getting your fish oils from tuna fish, forget it. You're only getting mercury. So, you know, why do I say this? Well, look at what your patients come in on. They come in on these capsules, but they're getting them at the health food store. They are very variable as to what fish oil they have. The studies are totally equivocal. This is the best study, the one that's the most positive, a Mayo Clinic study. They got 2 years here of fish oils. This is not progressing to renal failure. The fish oil group did much better than placebo. They just can't reproduce it. In large controlled trials, they're using the same fish oils, the same dose. They cannot do it. So fish oils, it's up to you. Don't stop your ACE inhibitor or A2 receptor blocker just because you're taking fish oils. And finally, steroids. It's not my slide. None of my slides move. So steroids. This was the first study. They took 86 Italian patients. They all had proteinuria and IgA nephropathy. Half of them got 6 months of steroids at a tapering dose. If you look at doubling of the creatinine, here's the control group at the end of 10 years. Here's the steroid group. End-stage renal disease, significantly better. That has been reproduced now in 3 other controlled trials. So the recommendation is if you have a significant amount of proteinuria that you do take 6 months of steroids to slow the progression to renal failure. And again, the recommendation is only in the last 5 years. So tremendous progress in terms of genetics, right here at Columbia as much as any place in the world. Progress in terms of understanding the pathogenesis and progress in terms of the treatment. Very important disease. The first time I saw, this is the International Grocers Association, so it's in Australia. This was up in Maine. When I saw this, I said, my God, these people are so far ahead of us in Maine. They put IgA on top of their stores in terms of this. You can get IgA cheese slices, you know, but nevertheless, when you see it now, think of IgA nephropathy. Let's take a 10-minute break. We're going to play Donald during the break.
Hi. Question, you were mentioning that it was showing up intermittently in kids who are playing soccer or doing something athletic. What does that have to do with it?
Okay, so well, we don't know sports does it, or even in upper respiratory infections. There may be sometimes with a fever or something, a little more stress. We know the IgA is already there. I mean, if you biopsy them the day they have their dark urine, it's there. What it probably is increased renal pressure, I think increased venous pressure, leads to more ruptures in the capillary leak, so the red cells come out. That's my guess of what's going on. But it's a pretty common thing, and it's also sometimes at an early phase, so somebody could argue, well, wait a minute, we'll see later, when we talk about anti-GBM and rapidly progressive, you can see ruptures in every capillary leak. But again, if you rupture a bunch of them, you get smoky urine. But that's it. It's either the fever, the pressure. I'd be interested to see what do you think in terms of why with sore throats and sporting events you get dark urine? I think it's just venous pressure probably on patients. Yeah. Okay.
What if there are people who have like chronic hypertension that have this issue?
Chronic hypertension don't get dark urine.
No, but I'm saying if they have that same genetic defect, if it's intermittent with people playing sports, if someone has chronic hypertension.
I mean, they have the underlying disease, but there's
It's a very good question, but I'm not going to mention it for the rest of the time.
We don't have to say anything. This disease is already there.
And the strep specifically is because it's such an antigenic. Because I know with
certain strains that can really and it may be the people who form the right antibody response against it, so you have to have a strain, you have to have the right If it's a custom,
Yeah, so that was maybe my question. I was wondering about the exacerbating effects. There's not some other like cardiac stuff, like pregnant women, mother leaves to be increased. No.
So, that's the theory, that's what people say. And, but, when people have a sore throat, most of them aren't. They don't even get that much of a temperature. When you get a sore throat, and it happens right, and there are patients who have it every time they have a sore throat, and you just have to reassure them. The hearing isn't getting rid of it. It's just, it's that smoke control.
And then my second question was in possibly in healing, right? Sorry.
So, they don't, but it's actually a very important area. One of the things I wish to talk to you better about is should we put in one of these, somebody who has the alternate therapy medical, and that's our biggest strength in the world for that disease is alternate pathway, because we have drugs now.
Right.
Now we have drugs that intervenes at the center for example, and intervenes at this but maybe for next year.
That's not this.
PNH is the rarest disease, I don't say it's the rarest disease, it is so rare. Because I used to say 50% of people develop renal failure over time. I've never seen it in my life. There's nobody in the world who's ever seen that. The next 40 years of so there must have been dialogue somewhere. Now they
My other question was about ACE inhibitors. Why is that? Is it because
increase right. And some people think they actually get less gross hematuria with it. But some people are put on ACE inhibitors and it doesn't make any difference. So it's not a uniform thing. But slowing the progression, every single study that's been done is neutral or positive. There are no negatives. Everything else is, if you look at tonsillectomy, there are many negative studies. Fish oil, very well done studies. We were involved in one big control one. 100 kids and then didn't make any difference at all. So, I tell people that I take fish oil. It's not going to hurt them, but the odds are it's going to cost them money. Evidence is not nearly as good as a generic drug like one of the pills.
And is there a particular reason why it affects specifically and not other areas?
Well, this may come back to what we just said in the beginning. Okay? Because again, immune complex disease, large number of networks, large surface area, etc. So I think it comes back to that why we get so many diseases in the kidney because of the vasculature.
So is it more that it blocks the surface area for filtration, or that it damages?
Well, it lands in the mesangian disease. That's what the inflammatory cascade. And then cells start coming in, and then you can get but usually, in most cases, it's very slowly progressing. That's one of the reasons it's been so hard to study, and that's why Berger program is totally benign. Followed the kids for 5 years, everybody was doing great. Followed for 10, it's not so good, 20, and now that we're getting people who've been followed for 30, 40 years, it's less good. Yeah, are we ready, or should we go ahead, or I want to?
We have one.
Let's see. Oh.
I wish I could freeze this, but I don't know how to freeze this one.
Oh, just escape.
You know, it's I'm going to give them another 2 minutes. I think we're doing good on time. You know, when they're already preparing to do the therapy, you know.
Okay, I think we're ready to proceed. Okay, we're ready for the 29-year-old saleswoman. So, the next case is also a very common disease, and especially for us at Columbia. It's a 29-year-old saleswoman who develops arthritis in multiple joints and fever. Frank arthritis with swelling of the joints, pain, etc. She also has lymphadenopathy, and she has a malar rash. She has a rash on her cheeks. She sees her internist. She has a urinalysis on that visit, 3+ protein, 18 to 20 red blood cells. She has red cells, she has protein, but we don't know. She doesn't have red cell cast. Nobody looked at the sediment. Her creatinine is 1.2, which again is probably going to be a low glomerular filtration rate for a 29-year-old female. Unless she's a trained athlete and does exercise every day, that's going to be a high creatinine. Her proteinuria is 1.8 grams per day. Her complement, again, is low. You're thinking of one of those 4 disease entities that we talked about. She has a positive anti-nuclear antibody, an anti-DNA double-stranded antibody is positive. Already you're saying this lady has lupus. She has clinical features of it, she has renal involvement, and she has the serology. So this is what the malar rash can look like. This is a bad malar rash. Sometimes it's just a mild flush, but sometimes it's much more. And this is what her kidney looks like. So what does her kidney look like? Yvette will go through the details.
Okay. All right, so not surprisingly, this young woman has a disease that we call lupus nephritis, which is a form of glomerulonephritis. And you can see on the low-power view, as we look at the kidney, we have a process with 4 glomeruli here that again is diffuse, involving all the glomeruli, and global, involving the entire glomerular tuft. This is the most severe form of lupus nephritis that we can see, and it goes by the name of diffuse proliferative lupus nephritis, very aptly, to describe the diffuse distribution of the proliferation and leukocyte infiltration. So this looks a lot like post-streptococcal glomerulonephritis on a low-power view, right? So as pathologists, we have to go a lot further. We have to do the immunofluorescence, we have to look at the electron microscopy, we have to get the serologies to narrow down our diagnosis and make a specific diagnosis of lupus nephritis as opposed to other forms of proliferative glomerulonephritis. So as we zero in on the individual glomeruli, we see the features of an active glomerulonephritis. You have proliferation of cells, mesangial and endocapillary cells. Again, look at the many infiltrating neutrophils here. It's a very active glomerulonephritis. And if you look carefully, you can see some peculiar material that's being deposited in the glomeruli here. These are immune deposits, and here you can see them along the peripheral capillary walls. They look different from those humps that I showed you in post-streptococcal glomerulonephritis. If anything, these seem to be on the inner aspect of the capillary wall, forming so-called wire loop thickenings of the glomerular basement membranes. We're going to see this better in some subsequent pictures. So again, the endocapillary proliferation, the leukocyte infiltration, and now we see deposits that look very different from what you saw in post-infectious glomerulonephritis. They seem to be beneath the glomerular basement membrane along the inner aspect of the capillary wall. These are subendothelial deposits. They're so large that they actually cause thickening of the capillary wall that we can see by light microscopy here, and some of them bulge into the capillary lumen, as you can see here. So this is very distinctive. So-called wire loop deposits were recognized by pathologists many years ago, and that name has stuck. But that told us that we are dealing with a massive immune complex load that is deposited primarily in the subendothelial zone. If we do our panel of immune staining, we see something very distinctive here. I told you in IgA nephropathy, the IgA is dominant. Sometimes it's the only immunoglobulin we see. But when we look at lupus nephritis, we see everything staining. We have IgG, we have IgM, we have IgA. We have complement components not just from the alternative pathway, but from the classical pathway. We have C1q, we have C3. So we have everything staining, and this has been called a full house pattern. And you can see that the deposition is in the mesangium and is also involving the peripheral capillary walls, almost semi-linear in its appearance because it's involving the subendothelial zone. Now, many years ago, when my kids were young, I was, preparing for this lecture to the medical students, and my son, who was in middle school, heard me talk about full house staining. And he said to me, "Mom, you keep using this term, full house. Do you know what that means?" Now, he was an expert poker player when he was in 8th grade. He used to beat out everybody. And he said, "It means 3 of a kind and 2 of a kind." And I said, "Wow, I've been saying this all this time, and I didn't realize that the 3 of a kind was all 3 immunoglobulin classes, and the 2 of a kind was both complement components." Now, this 8th grader is now an international lawyer who spends half his time in Paris and half his time in New York, arguing cases, and you can see that learning to play poker in 8th grade is a very valuable tool. So here are the subendothelial deposits, and you can see them, as I showed you, by light microscopy. Here, by immunofluorescence, they're seen, and by electron microscopy, you can identify that they're subendothelial in location. One aspect of this is that we can see their subendothelial just by their conformation when we look on very high power by immunofluorescence. You'll notice the outer portion of the deposit is smooth. The inner portion is more irregular, as you see here by electron microscopy. That's because the outer portion is delimited by the glomerular basement membrane itself, which imparts a smooth contour to this outer aspect of the deposit, and that helps us localize these deposits as subendothelial in distribution. Another characteristic feature that we see in lupus nephritis is so-called hematoxophil bodies, which also go by the name of LE bodies, or lupus erythematosus bodies. What these are actual extruded nuclei that have been altered by binding of anti-nuclear antibody in situ here in the glomerulus, and have undergone a clumping of their chromatin. Now remember, normally nuclei are sequestered inside the cell, and anti-nuclear antibody can't bind to it when a cell is a living cell. But after cell death, for example, after leukocytes have come in, they've been activated, they undergo respiratory burst, and then they die, the nuclei may become exposed to the ambient circulation. Anti-nuclear antibody can bind, and these extruded nuclei undergo this peculiar clumping, and they pick up the hematoxylin stain, and so we call them hematoxophil bodies. But that is a pathognomonic feature of lupus nephritis. We don't see that in any other disease. It's a rare feature, but when we see it, we know it's lupus nephritis. So this is a disease where we have immune complexes forming, and these are usually present in the mesangium to start with, and then as the disease becomes more severe in these diffuse proliferative forms, they overload the mesangium and actually break out into the subendothelial regions, as shown here. There is a defect in tolerance to self-antigen, and these patients develop antibodies to a whole host of different components of the cell, particularly to DNA, and most importantly to double-stranded DNA, which is the most pathogenic of the antibodies. There are many classes of lupus nephritis, and I don't want you to remember them by this WHO classification, which, by the way, was revised right here at Columbia about 10 years ago by a big group of nephrologists and pathologists. This is our current classification, which is a revision of the WHO. But I just want to point out that the disease can have mild forms and it can have severe forms. It can go anywhere from mesangial proliferative to an even milder form where we just have mesangial immune deposits with no proliferative response, focal proliferative involving less than 50% of glomes, diffuse proliferative, which I just showed you, even a membranous form, which I alluded to in our talk on Monday, and in an advanced disease, chronic sclerosing. So the renal biopsy plays a very important role here. And I'll just show you a few of these different forms. Here's the mesangial proliferative form where the capillary lumina are patent, and again we see full house immune staining, but it's confined to the mesangium. These patients have a little bit of hematuria, a little bit of proteinuria, they don't develop nephrotic syndrome, they don't develop a reduction in GFR, and usually the treatment is directed to the extrarenal symptoms and signs rather than to the glomerulonephritis itself. So they tend to fare well. And you can see the deposits here within the mesangium and not involving the peripheral capillary loop, which is intact. So that's the mild mesangial form. We can have focal proliferative forms where the deposits form in the mesangium and also in the subendothelial zone, inciting the endocapillary proliferation, but it's relatively focal and segmental in distribution. We see that sometimes. Sometimes there can be crescents associated with them. And then we have a form that is membranous. So this is always in the differential when we have a young woman who develops a membranous form of glomerulonephritis and who has the spiking, which I've showed you before yesterday, has full house staining and typically deposits in the mesangium. Even before that patient is known to have a positive antinuclear antibody, we have to suspect membranous lupus nephritis, not primary membranous glomerulopathy. So all these forms can actually transform over time. The clinicians and Dr. Appel, as a master clinician in lupus nephritis, have to be very vigilant to look out for possible transformations and to time the biopsy at the right time, because these more severe forms require aggressive therapy, as he will show you.
So one of the things that you've heard Vivette say over the last few days is that one entity like membranous nephropathy can have many different etiologies. You know, it can be idiopathic, it can be lupus-related, hepatitis B-related, and one disease like lupus nephritis can have many different patterns. Now, there's probably no disease that we rely more upon the biopsy than lupus, because our treatment is focused on what we find on that biopsy. If you have class 1 and class 2, just minimal and mesangial, we don't treat the kidney involvement. We focus instead on the joint pains, the rash. We treat those symptomatic things rather than focusing on the kidney. If we have a membranous pattern, we only treat those with very heavy proteinuria. If you have a membranous pattern and you only have a gram of proteinuria, you're not going to have progressive disease. If you have advanced sclerosis, we prepare the patient for renal replacement therapy with dialysis or transplant. If they have focal or diffuse proliferative lupus nephritis here, that's where we treat with steroids and immunosuppressants, because that's where it's made the biggest difference over time. We have very good randomized controlled trials to show that these patients will not go on to progressive damage. Most of them will be able to resolve the inflammation in the kidney. So how do we treat bad focal proliferative and diffuse proliferative lupus nephritis? We can use steroids, but you can't use them alone. If they're alone, they're ineffective and they'll have many side effects. Azathioprine, not effective. Cyclophosphamide, which was the standard for many years, is effective, but it has side effects. And now many people are using an alternate regimen of cyclophosphamide to get away from this, or another drug, a medicine we use in transplant all the time now. Mycophenolate mofetil is used in transplant. It's actually replaced azathioprine in transplantation. And we have many newer therapies we're studying. So why do we want to get away from steroids? cushingoid appearance. The first thing this young lady said when she came into the office is, Dr. Appel, you have to have something other than steroids to treat my lupus nephritis. And of course we do. But you couldn't get a rounder face here again and just the cosmetic things. Now remember, 90% of lupus patients are young, 90% are female. Those cosmetic effects are devastating. I mean, it can just ruin somebody's entire life. Some of them, like the moon face, goes away. But stretch marks, they may change colors from going purplish to white, but they don't go away over time. So how bad are the stretch marks? Here's a 19-year-old who got treated. He was the captain of his high school football and basketball team. I mean, that's not very pretty. I mean, the guy really was a mess after this. So again, you can use steroids, but you've got to use them in the right fashion, taper the dose down. I mean, and one of the most important things is looking at these cosmetic side effects, because your patient is going to stop the medication if they're starting to get side effects. I mean, like steroids, acne. I mean, like, having, I'm getting up to the grandchild age now, but having gone through teenage years with the kids, one pimple is devastating. I mean, you get a lot of acne from steroids, so that's just a disaster. Now, lest you think that cyclophosphamide is so benign, here is a study where they looked at cyclophosphamide or cyclophosphamide plus steroids, but I just want to point out all of the side effects that are in this group. Here's a big one, premature menopause. Cyclophosphamide causes premature menopause. Again, that is a big thing. Infertility, long-term in young female population, huge. It also causes hair loss. Not so good. So again, it's effective, but you need a better regimen to use it on. The good thing is, over the last 20 and especially the last 10 years, we focused in on getting better regimens that have fewer side effects. So now if you have bad lupus nephritis, you either get mycophenolate mofetil, no cosmetic effects with a tapering steroid dose for 6 months, or you get cyclophosphamide, but the vast group of people would use it on an altered regimen where it's much less low-dose cyclophosphamide, so you don't get the hair loss, so you don't get the bleeding problems in the bladder, so you don't get infertility, etc. And once you've had 6 months and you've gone into remission, then you go on maintenance therapy with mycophenolate or azathioprine. Here, if you're doing well, you get on this for the next 3 to 4 years. You get through college, people get married, etc. They get jobs, they get settled down. In the formative years, they're not relapsing and needing retherapy and readmissions to the hospital. If you don't respond after 6 months to this, you get put on this arm and you try this regimen. If you don't respond to this regimen if you started it, you get swung to this one. So we have 2 very good therapies. We have choices now for the patient with lupus nephritis, which we did not have 1 decade ago. And these are all large randomized controlled trials, which we've played a major part at Columbia. Okay, we are ready for our next case. This is a 58-year-old insurance salesman who develops sinusitis, weight loss, malaise, this feeling of illness, and a dry cough over a 3-week period. He goes to his internist and he has sinus films taken and they show opacification of the left maxillary sinus. His left maxillary sinus is totally opaque. He has active sinusitis. He's been coughing. He gets a chest x-ray. He has a cavitary lesion in his lung. Other labs that were done, urinalysis, red cells, white cells, red cell casts. He has glomerulonephritis. So he has upper airway disease, sinus disease, he has lung disease, and he has kidney disease. Creatinine markedly elevated at 2 milligrams per deciliter. Normal would be about 1 for him. Serum complement is normal. Anti-GBM antibodies are absent. He has a test for anti-neutrophil cytoplasmic antibodies, and it is strongly positive. If we look at this person's sinus films, here you can see opacification of the sinus. If we look at this person's chest x-ray, here you can see a cavitary lesion here in the left lung. And if we look at this person's glomeruli, you'll see what Vivette will show you.
So let's go to the videotape and see what the glomerulonephritis looks like. So you've already gotten the sense that this patient's disease with ANCA positivity fits with upper airway, lower airway, glomerular disease, and we're already thinking about Wegener granulomatosis, especially with the cavitary lesion in the lung. And sure enough, that's what we find on biopsy. Now, I've shown you a lot of different examples of the way glomeruli can undergo proliferation, but here we're going to focus on a crescenteric process, one where the proliferation is outside in the urinary space here. And I'm showing you a silver stain because you can see how beautifully it highlights the basement membrane of the glomerulus, the mesangium, the glomerular basement membrane itself, and Bowman's capsule. And we can very clearly see that we have a necrotizing process with areas of dissolution of glomerular basement membrane and proliferation out here, primarily in the urinary space. These are the crescents, the semilunar lesions that I showed you earlier. Sometimes can involve the entire glomerular tuft and be circumferential. If we go on very high power, we can see the damage to the glomerular tuft. Whenever you have a crescentic process, you can expect that you have severe damage to the tuft. And in this case, the lesions are necrotizing. When we use the term necrotizing, we mean that there is fibrin extravasation into the urinary space here, and also glomerular basement membrane rupture. And we even see some blind-ending glomerular basement membranes here. We never see that normally. The glomerular basement membrane is everywhere continuous, so when you take a cut of the kidney in 2 dimensions, you should never see a break in the GBM. Whatever direction it's going, it's continuous. But here we actually see ruptures. So this is a very severe necrotizing process. When we do our immunofluorescence panel, unlike the lupus case, which was full house, we see something very surprising here. Despite the fact that this is such a severe glomerulonephritis, we have no immune reactants other than fibrin. Fibrin is something we stain for, but it's the only thing we see. We see it in the crescents, but there are no immunoglobulins. So this is not a disease where we have antigen-antibody complexes forming in the glomerular tuft. Something else is going on. And here's the fibrin and the distribution of the crescent. When we go to the electron microscopy, correspondingly, I told you the immunofluorescence was negative for immunoglobulins. There are no electron-dense deposits here. Here's the glomerular basement membrane. What we do see is rupture sites in the glomerular basement membrane. Here you see just a fragment of glomerular basement membrane, which ends here. And you can see a crescent out here, which is continuous with the endocapillary zone. Very destructive lesion, but no electron-dense deposits. So the mediation of this disease is not involving immune complex deposits. I have a friend out in the Midwest who has a cottage industry of doing scanning electron microscopy on glomeruli. And he gave me this picture where he has a way of digesting the epithelial cells off of the glomerular tuft and then doing scanning electron microscopy of the outer aspect of the glomerular basement membrane. And what you can see in this disease is amazing. You actually have rents in the glomerular capillary wall, huge holes. So the leukocytes are coming in, they're releasing their enzymes, they're digesting huge portions of the tuft in 3 dimensions here. I showed you blind-ending GBMs in 2 dimensions, but these are huge holes. Not surprisingly, these patients are getting a massive amount of hematuria through these openings. Sometimes in these biopsies, we can see actual vasculitis involving vessels. Here's an example of one, but this is not common. I would say less than 15% of our cases will actually have vasculitis involving arteries or arterioles in the biopsy. Mostly what we see is glomerulonephritis, which you can think of as a vasculitis involving a capillary, the smallest vessel possible, a capillary bed, the glomerular capillary bed, which is a glomerulonephritis. In the lung in these patients, sometimes we have pulmonary capillaritis, and you can see the leukocytes here within the alveolar capillaries, and this can lead to hemorrhage. And these patients often present with hemoptysis. They have a necrotizing capillaritis in the lung in some patients. Others may have granulomatous lesions. In the sinuses, we have a lot of inflammation with granuloma formation. The bone is sequestered and damaged. And some of these patients even develop saddle deformities of the nasal septum so that they have collapse of their nose, almost look like a they've been fighters in the ring, but the actual bone and cartilage has been destroyed by the granulomatous process in the upper airway. So what is the cause of this disease? If there are no immune deposits here, we have a lot of leukocytes infiltrating, we have crescent formation. We now know that the serology that we measure, anti-neutrophil cytoplasmic antibody, is not only a marker of the disease, it's also pathogenic for the disease. We do this testing for ANCA in two ways. One is by indirect immunofluorescence, and the other is by ELISA to identify what the ANCA target is. By indirect immunofluorescence, because the two targets, proteinase 3, which gives us a C-ANCA pattern, and myeloperoxidase, or MPO, which gives us a P, or perinuclear pattern, if done on formalin-fixed neutrophils as substrate, because these antigens are located in lysosomes, they are correctly localized to the cytoplasm if we use formalin-fixed normal neutrophils as substrate for the test. You take the neutrophils, you apply the patient's serum, and then use an antibody to IgG and see where it forms. On the other hand, if you take alcohol-fixed neutrophils, because the myeloperoxidase is very nucleophilic, the alcohol-fixed neutrophils, this is a very weak fixative, allow the antigen to move to the surface of the nucleus, the nuclear membrane, and so we get a perinuclear pattern. It's really an artifact just of using alcohol-fixed neutrophils as substrate, but it's a useful artifact. So by indirect IF, we see a perinuclear pattern when the antigen is myeloperoxidase, a cytoplasmic pattern when it's proteinase 3, but you really need to do the ELISA to know the specific antigen that's targeted by the ANCA antibody. So how do these ANCA form disease if we have no immune complexes? The ANCA antigens are located within the primary lysosomes and azurophilic granules of neutrophils and in the monocytes as well. What we think is happening is that there's a priming event. You may have antibody to the ANCA antigen, but it can't affect the neutrophil unless you first are primed, for example, by TNF-alpha or some other cytokine, and then these lysosomes move to the surface of the cell, and the ANCA antigen is now expressed on the cell membrane. Here, it can interact with ANCA antibody, both by Fc receptor interactions and by FAB'2 interactions. It can stimulate the neutrophil to undergo a respiratory burst and release lysosomal enzymes onto endothelial surfaces. So actually what we're getting is neutrophil activation by the ANCA and not immune deposition within the capillary walls. So this is a neutrophil activation and degranulation on capillary beds. It can take place in the kidney, it can take place in the lung. Now the disease was first described by a man named Wegener, who was a German pathologist who was actually active in the Nazi Party in Lodz, Poland. That's actually, I think, where Chopin was born. And he received a big prize from the American College of Chest Physicians the year before he died in 1989 for the discovery of this disease. And then in the year 2000, it was discovered that he was actually a participant in medical experimentation by the Nazis on patients, like giving them air emboli. And then he would do autopsies to see the effect of injecting air into the veins and all kinds of things. So you can imagine that they want to move away from calling this Wegener granulomatosis. People are getting away from eponyms in general. And there's a move to call this disease granulomatosis with polyangiitis. We don't want to identify this man. They rescinded his prize, by the way, in 2000. Too late for him to know. But GPA, or granulomatosis with polyangiitis, it's your generation that's going to be calling this disease by that name. My generation is still going to remember Wegener granulomatosis because it's so entrenched in our thinking. But it's your generation that's going to change it. So when we talk about pulmonary vasculitic syndromes, this ANCA-associated disease is high on the list. It's extremely common. It's a pauci-immune form of glomerulonephritis where we do not have immune deposits, and we have two major subtypes, Wegener granulomatosis or granulomatous polyangiitis and microscopic polyangiitis. We can have pulmonary renal syndromes due to immune complex disease. Sometimes we see it in patients with lupus nephritis or cryoglobulonemic vasculitis. And we can see it also in patients who have a rare disease called anti-GBM nephritis. Here, rather than having a pauci-immune picture, no deposits, or granular picture as in lupus, we have a linear pattern of staining by immunofluorescence. And when we have both the nephritis and the pulmonary involvement, it goes by another eponym. A man named Ernest Goodpaster first described it, but he was a good guy, so we still use the term Goodpaster syndrome to describe the pulmonary renal manifestations of this disease. So here's how we look at this as pathologists. We have pulmonary renal syndromes. We have circulating anti-GBM antibody that can give us a linear pattern of staining. I'll show you this in a moment. We have an immune complex pattern, as we can see in a patient with lupus, for example. And we have an ANCA pattern, a so-called pauci-immune, where if you stain by immunofluorescence, we find no immune reactants. And here we're dealing with a neutrophil activation response. So the pattern by fluorescence is critical to the categorization of these diseases. So just for completion, I'd like to contrast this ANCA case with another form of severe crescentic glomerulonephritis, anti-GBM nephritis. Fortunately, this is a very rare form, but we still see about, I would say about 20 cases a year in our lab. And it also has diffuse crescents with necrotizing features in the tuft. Here you can see the crescent, which in this case is circumferential, and the presence of fibrin here in the urinary space. Fibrin is a growth factor for the parietal cells and induces this tremendous proliferative response and the formation of the crescents. The fibrin stains red, as shown here with our trichrome stain. If we do immunofluorescence in this disease, rather than the pauci-immune pattern, if we stain for IgG, we see linear staining. It's as though you took your pencil and you just drew directly on top of the glomerular basement membrane. There are no discontinuities here, no lumpy granular quality. What you do see is some breaks in the glomerular basement membrane, some blind-ending glomerular basement membranes, which represent the sites of rupture, because this also is a very destructive form of crescentic glomerulonephritis. So here we have a disease that is caused by an antibody circulating to an epitope that's in the collagen 4 of the glomerular basement membrane. It's actually directed to the glomerular basement membrane itself. The GBM is the target of the immune response. It's a very unique disease. And because of this stoichiometry, a one-on-one antibody-to-antigen relationship, and the very regular distribution of the antigen within the glomerular basement membrane, we see the staining as linear when we stain for the IgG. This is not a random deposition of circulating immune complexes somewhere in the glomerular basement membrane. This is very regularly distributed, and so we see linearity. The mechanisms of injury are very similar. The immunoglobulin activates complement, chemotactin C3a, C5a attract leukocytes, which release their enzymes onto the glomerular basement membrane, causing large gaps to form. With the activation of the fibrin and clotting cascade through the endothelial injury and the basement membrane exposure, fibrin can pass now into the urinary space where it is a growth factor for parietal epithelial cells and stimulates crescent formation. And here we see the antigenic target. It is on a portion of the collagen 4 molecule. The so-called Goodpaster antigen is located in the non-collagenous domain. And what's interesting is that this antigen is also present in alveolar basement membranes. Remember, collagen 4 forms the framework for vascular basement membranes throughout the body. So it's also present in the pulmonary capillary basement membranes. And what we think is that normally this antigen is sequestered in the hexameric structure of these collagen 4 molecules. But if there's an injury, maybe first to the lung, for example, if you have hydrocarbon exposure or influenza, it can open out these antigenic sites that are normally hidden or masked, and now the Goodpaster antigen is exposed. It's about a 40 amino acid portion of the molecule, and an immune reaction can form to it, and we can develop the pulmonary hemorrhage, the capillaritis, and the glomerulonephritis. So there may need to be first an exposure by an inflammation, probably at the level of the lung. And here, not surprisingly, if we take lung tissue and stain it for IgG, the alveolar basement membranes will also give us a linear reaction because the antibody is forming here to the pulmonary capillary basement membranes, which contain the same collagen 4 molecule. sometimes the hemorrhage that results is fatal, and this is a case that came to autopsy here at Columbia. It was a very, for me, a very traumatic case because I was a first-year resident and had to do an autopsy on this patient who had massive pulmonary hemorrhage from Goodpasture syndrome. And I had known the patient because some weeks before, this patient had such a severe glomerulonephritis that before there were good therapies for this disease, they actually resorted to doing double nephrectomy on the patient. They wanted to take out the source of the antigen. This was the thinking in those days. And then there would be less immune response, and hopefully we could save the lungs from massive hemorrhage. So I was able to analyze the kidneys way back in 1980, and you can see the same flea-bitten quality to the surface of the kidney that you saw in post-infectious glomerulonephritis in this patient. And this again is due not to a flea biting the surface of the kidney, but to the many red blood cell casts that are actually visible just from the surface of the gross kidney with the naked eye. Massive hematuria as seen here with the red cell casts. Fortunately, it's a disease that's quite rare, but devastating.
Now, we actually do phenomenally well at treating ANCA-positive RPGN now, still less well with this disease because it's so fulminant. So, let's go back one. So, clinicians often speak about rapidly progressive renal failure, rapidly progressive glomerulonephritis. This is a form of glomerulonephritis that goes to renal failure in a matter of weeks to months, downhill very fast, as opposed to diabetic nephropathy or IgA, something that's slowly progressive over a long period of time. You can think of it this way. The clinician talks about RPGN, the pathologist talks about crescenteric glomerulonephritis. They go hand in hand. You're always going to see those crescents in the people who go downhill very fast. It's a bad prognostic thing. Pathogenetically, Vivette has shown you there's anti-glomerular basement membrane disease. There are immune complex diseases that can give you crescents, like lupus can do this. And there's pauci-immune or ANCA-positive RPGN. Most important, the treatment and course depends on the etiology. And the etiology we know as soon as we have the immunofluorescence. As soon as we know if it's linear, if there are no deposits, or if it's lumpy, bumpy, granular for immune complex, we already know the etiology even before we don't have the serologic test back yet. For anti-GBM disease, you could almost figure out what you do. You give them steroids and cytotoxics to block the production of anti-glomerular basement membrane antibodies. You give them plasmapheresis to remove any antibodies are there. And many of the patients, especially if the renal damage isn't severe, have a good recovery. For immune complex disease such as lupus, you treat the underlying condition. We showed you for bad lupus, even if you have crescents there, you can either treat with mycophenolate or you can treat with cyclophosphamide and you'll get good resolution. And if you have ANCA-associated pauci-immune glomerulonephritis, you either give cytotoxics. Now we have a newer agent. Rituximab is largely replacing this because it seems to be more benign. But again, it's a monoclonal antibody that blocks the immune system here. You can use those with steroids and plasmapheresis if it's a bad case. Again, the therapy is directed at the pathogenesis, and the pathogenesis is defined by the immunofluorescence there. Now, the last thing I want to say is that ANCA sometimes confuses people, and for some reason, even the medical students know if they have a lupus patient who has a high titer ANA and a high anti-DNA antibody, that's bad news. That they have active, it defines the disease. They probably have lupus, like our case, and they probably have bad disease if they have a very high titer. So this is one way to think about it. ANCA is to pauci-immune RPGN as anti-DNA is to lupus. If you have a positive titer, especially a high titer, you are very likely to have pauci-immune RPGN. And if you treat the patient, the ANCA titer falls down over time. If they get a flare of the disease, it goes up. Just like the anti-DNA, if you treat the lupus patient, it goes down. If they're doing well, it stays down. If they have a flare, it goes up. So ANCA is to RPGN as anti-DNA is to lupus. So we'll stop here. You've seen how closely the nephrologist and pathologist have to work together. Tomorrow I have to work closely with two pathologists. I get both Barry Stokes and Glenn Markowitz for tubules and vascular disease. We'll see you then.
Why are you taking the battery? Hoping to get me some AAA. Triple. Oh, oh, you're very welcome. I think so too.
I'm just going to copy this on here. Let's see.
Sorry, that was me. There you go.
Oh, very good. Okay, so let's see. So copy this. Let's see. File. Save as. Okay, now let's see. My thumb drive is not there.
I think if you
Oh,
click
no,
computer, it'll come up.
Okay, now, yeah. There it is. Okay, paint shop.
Okay.
Okay, so now I just save it. Okay, it is working. Actually, I think the other day I was just going to close it and just take a quick look at it. 'Cause
Sure.
first I thought I had that on Monday and apparently didn't. It's a long file. You know that has to spin a lot. I'm trying to save it again, but this time I'm going to close it and open it and
I
see if
don't
it's
know
there.
if Glenn is going to do his usual jokes and then...
I'm going to tell him not to do, we've told too
Don't
many
have
jokes.
time.
Yeah, we don't have time for that. I mean, like, you can't
Okay,
run
we'll
over
tell him
into
then, because I
Barry's.
think he's
Getting
planning.
serious.
Oh, well, I won't answer back with another joke.
Okay, yeah, don't
If
counter
he does
it.
a joke, that's fine, he's
Yeah.
on his own.
Yeah, there's no...
If he wants a vice chairman of the pathology department to be remembered because of his Jewish kid jokes
Yeah.
or something. Yeah. Let's see, why is that?
You know, Jerry, if you come to my office, I'll give it to you.
No, I think it should be on here, though. I thought
For
it
some reason, we have it...
but it's still going. Now, why is
I
it?
think you don't have room on your...
You'd think so, but it
Yeah,
usually
it is.
says that, but maybe I don't have room
Yeah,
because
you
it's so
don't have,
big.
it doesn't tell you, but you're too...
Okay,
too
we could
full.
try one other one. You're right, it's still not.
Yeah, if it's not saving, it's because you have no room.
Press the cancel.
Just cancel.
Yeah, okay.
And then,
Okay, so you know what we'll do, we'll get it on the disk or something. That's probably
you know,
what
I
it
can give it, if you come by to my office, Jerry,
Yeah,
I
I
can
will.
just put it on your...
Yeah, sure, that's fine.
On your one that has more space.
Yeah, good, I'll bring in an empty one. Okay, great, thank you.
You're welcome.
There's no point in dwelling on. Yeah, I think, I'm trying to, I know I have slides.